Hello everyone. This presentation will take you through the overview of the common antibiotics that we are using in our daily practice. We will cover the different classes of the antibiotics and their mechanisms of action, the differences between bactericidal and the bacteriostatic antibiotics, along with the examples, will also be explained here. Additionally, we will also discuss the difference between the broad spectrum and narrow spectrum antibiotics, providing examples for each of them. We will also present different sites of infections. Following this, a table will present the tissue distribution of each antibiotics. Finally, we will discuss common side effects of them. So, what is antibiotics? Antibiotics are drugs to treat bacterial infections. There are different classes of antibiotics based on their chemical structure, which targets the different parts of the bacteria. Now, let's discuss about the classes of the antibiotics. The first one is beta-lactams. There are four types in beta-lactams: penicillins, cephalosporins, carbapenems, and monobactam. The another group is aminoglycosides, such as gentamicin, streptomycin, amikacin, and tobramycin. The third group is fluoroquinolones, which includes ciprofloxacin, levofloxacin, and moxifloxacin. The fourth group is the glycopeptides, as an example, which is vancomycin, teicoplanin, and dalbavancin. The fifth class is macrolides: azithromycin, clarithromycin, erythromycin, figdazomicin are the examples of the macrolides. The next class is called lincosamides. The example for this is the clindamycin. Another class is oxazolidinones, such as linezolid and tedizolid. Nitroimidazole also treats for the anaerobe infections. They are metronidazole and tinidazole. The another class is the tetracycline. As an example, there are doxycycline and tigecycline. The last class of the antibiotic is the sulfonamides. Sulfamethoxazole is the common one, which we normally use combination with trimethoprim. We also call as a cotrimoxazole. Now let's discuss how these antibiotics act on bacteria. In other words, what is the mechanisms of the antibiotic infection action, We can basically divide into three main mechanisms. The first action is on the cell wall synthesis. All beta-lactams bind to and inactivate the enzymes that are required for building bacterial cell walls. This loss or damage of the bacterial cell wall leads to the cell death. The second antibiotic class, which also acts on the bacterial cell wall, is glycopeptide. It inhibits the growth of the bacterial cell wall. Since they share the similar mechanisms of action, we can use glycopeptides if the patient is allergic to penicillin or resistant to penicillin. The second main mechanism is antibiotic action is nucleic acid synthesis. Fluoroquinolone inhibits DNA gyrase and topoisomerase enzymes, which are necessary for DNA replication. Nitroimidazole also inhibits the DNA synthesis, causing the bacterial cell death. The third mechanism of action is on protein synthesis of the bacteria. Ribosome is part of the cell component which act as machine in protein synthesis. Oxazolidinone acts on 70S ribosome and it inhibits protein synthesis. While aminoglycosides and tetracycline also inhibit protein synthesis by acting on 30S subunit ribosome. Macrolides and lincosamide also disable 50S subunit ribosome and cause the bacterial dying. On top of these main mechanisms, Sulfonamide and trimethoprim inhibit the enzyme necessary for folic metabolisms of bacteria. In this way, they inhibit the growth of bacteria. The drug affects not only the folate pathway of bacteria but also that of human being. Therefore, folic acid supplements should be prescribed for those who need to use high dose of cotrimoxazole, example for the toxoplasmosis. Antibiotics can generally be split into two different groups. Bactericidal is the antibiotics having ability to kill the bacteria. Bacteriostatic is the antibiotics having the ability to stop the bacteria from growing. So, which antibiotics are bactericidal and which ones are bacteriostatic? Beta-lactam, aminoglycosides, glycopeptide, nitroimidazole, and fluoroquinolones are bactericidal antibiotics, whereas oxazolidinone, lincosamide, tetracycline, sulfonamide, macrolides are the bacteriostatic effect. Therefore, it is not recommended to treat severe infections like meningitis or endocarditis with those drugs alone. Antibiotics like lincosamides are usually bacteriostatic in standard dose, but it can become bactericidal at higher doses. Now, we should explore which antibiotics work for which parts of our body so that you can choose antibiotics for better empirical therapy. Let's start from the top. Beta-lactam is used to treat meningitis. For eyes and nose infections, aminoglycosides, macrolides, and fluoroquinolones can be used. Macrolides and fluoroquinolone are also used for the sinusitis. Tetracycline can be used for nose and mouth infection. Dental infections, including the abscess, should be treated with beta-lactam or the nitroimidazole. Let's look at the antibiotics for upper body. There are several antibiotics which can be treated for respiratory tract infections. Some have special effect. Aminoglycoside and glycopeptides are for the hospital-acquired pneumonia, while tetracycline is for community-acquired pneumonia. Sulfonamide is used also for pneumocystis jirovecii infection. Beta-lactam is effective against endocarditis as well. Let's move to the lower body. H. pylori infection can be treated with nitroimidazole, tetracycline, and fluoroquinolone. There are certain antibiotics which are effective to treat intestinal infection and peritonitis, such as beta-lactam, glycopeptides, nitroimidazole, lincosamide, and fluoroquinolone. Urinary tract infection is common infection, and aminoglycoside, beta-lactam, sulfonamide, and fluoroquinolone are the drug of choice for UTI. Regarding the pelvic and genital infections, fluoroquinolone, lincosamide, and tetracycline can be used. Bone and joint infection can be treated with beta-lactam, oxazolidinone, glycopeptide, lincosamide, and sulfonamide. For skin and soft tissue infections, glycopeptide, nitroimidazole, oxazolidinone, tetracycline can be used. Lincosamide is used for sepsis secondary to skin and soft tissue infection. Indeed, antibiotics are used for not only treating the infection, but also be given as prophylaxis. In surgical procedure, use either beta-lactam or aminoglycosides or glycopeptides or fluoroquinolone. Regarding the malaria prophylaxis, which we can say as the medical prophylaxis, in this case, we can use tetracycline. Example, we use doxycycline. So now let's talk a little bit about the pharmacokinetics. Aminoglycosides are poorly absorbed via the gastrointestinal tract and thus are administered via the intravenous or intramuscular route. Since they are good for extracellular penetration, it is suitable to treat bacteremia. Due to its poor tissue penetration, it is not appropriate to use it alone for deep-seated infection. Aminoglycosides are rapidly cleared through the urinary tract, which is also makes these drugs ideal for the treatment for urinary tract infections. Penicillin's oral absorption varies by type and is available in both oral and injectable forms, with differences in tissue distribution as well. Due to their short half life, regular redosing is necessary to maintain effectiveness and prevent resistance. Cephalosporins are available in both oral and injectable forms. They have good tissue distribution, making them commonly used at empirical treatment for various infections. Generally, their half-life is short, except for ceftriaxone, which has a half-life of 8.5 hours. Therefore, it is sufficient to give ceftriaxone once daily. Most cephalosporins are primarily excreted by the kidneys, except cefizim, which is excreted via bile. Carbapenem and monobactam have poor oral absorption, therefore they are available only injection. Meropenem and imipenem penetrates CSF if meninges is inflamed. Therefore, you can use it for the patients with meningitis. Since they are excreted via kidney, dose adjustment is needed for renal impairment patient. Oxazolidinones are good in oral absorption. They have very good tissue penetration to bone and skin as well. Therefore, they are recommended to use for osteomyelitis. Glycopeptide had poor oral absorption properties. It can also be treated for gram-positive meningitis due to their penetration properties to meninges when it is inflamed. Since it is also secreted via kidney, dose adjustment is necessary, especially in vancomycin. Nitroimidazole is also commonly used antibiotic since oral form is available and is widely distributed throughout the body. Oral availability is good in lincosamide and good distribution to tissue, especially to bone and skin, but not to CSF. Half-life is short and repeated doses needed. Sulfonamide can rapid be absorbed via oral route. They distribute also in lungs and CNS. Half-life is long and is excreted via renal. Therefore, dose adjustment is needed for those who have renal impairment. Macrolides are also good at bioavailability and have good distribution to both tissue and blood. Most of the macrolides' half-life are short, except azithromycin, which lasts 4 days. Therefore, azithromycin can be prescribed with short duration. The elimination depends on individual drug. Example, clarithromycin is excreted via kidney, while azithromycin is through biliary excretion. Fluoroquinolone has very good oral bioavailability and are widely distributed throughout the body. The excretion route is varied from renal to hepatic. Tetracyclines are also good at oral absorption except for tigecycline. They are also good for tissue and bone penetration, and some have CNS penetration. Half-life is varied from 6 to 12 hours, but tigecycline half-life is very long, 27 to 43 hours. They are excreted via feces. So after we talked about the tissue distribution, we can also divide the antibiotics into broad spectrum and narrow spectrum antibiotics. Broad spectrums antibiotics are those which can kill or inhibit the growth of the wide range of the bacteria, can be both gram negative, gram positive, or even can be the anaerobe. Narrow spectrum antibiotics are the antibiotics which can kill or inhibit the growth of the specific bacteria. Example, vancomycin, which is active only for the gram-positive bacteria. Carbapenem, cotrimoxazole, macrolides, and fluoroquinolones are the broad-spectrum antibiotics. However, among broad-spectrum, some are broader than others. Penicillins and cephalosporins are broader spectrum if combined with beta-lactamase activity, example, co-amoxiclav. Cephalosporins show increasing gram-negative activity in later generations. Nitroimidazole has both anaerobe and antiparasitic activity. Lincosamide is active against many aerobic gram-positive cocci as well as many anaerobic gram-positive and gram-negative organisms. Aminoglycoside targets 2 gram-negative, including Pseudomonas aeruginosa. Monobactam all target gram-negative, but not all of them. All strains of Pseudomonas aeruginosa may be susceptible. Glycopeptides and oxazolidinones are effective against gram-positive only. Now, let's talk about the side effect. Each and every antibiotics have different side effects. Some are similar among them. Some side effects are mild but very common. Some are severe but can be fatal, but they are rare. The common side effect of both aminoglycosides and glycopeptides include nephrotoxicity, ototoxicity. Aminoglycoside can also cause neuromuscular blockade and increase muscular weakness, making them contraindicated to use in myasthenia gravis. Infusion syndrome can be used by first dose of vancomycin or rapid infusion of vancomycin. It is also called as Redman syndrome. It can be mistakenly with a true allergic reaction. Infusion syndrome can be prevented by slow infusion of pre-medication with an antihistamine. Cephalosporin can cause rash, diarrhea, and nausea and vomiting, but they are uncommon. Nitroimidazole can cause nausea and vomiting if taken together with alcohol. Similarly, lincosamide also cause allergic reaction, abdominal pain, and diarrhea. 10% of penicillin use can cause rash. 1% can cause anaphylaxis. If high dose or prolonged use of penicillin can cause seizure or bone marrow toxicity. Additionally, cephalosporin is also a risk of the Clostridium difficile infection. Carbapenem is well tolerated in general, but there can be bone marrow toxicity in prolonged use. It is also safe to use in penicillin allergy, except anaphylaxis. Oxazolidinone can also cause bone marrow toxicity like carbapenem. It has other common side effects such as optic neuropathy and peripheral neuropathy. Macrolide can cause rash, transient hearing loss, and QTc prolongation. Fluoroquinolone can also prolong QTc if it is used in long term. Other side effects of fluoroquinolones are GI upset, insomnia, and spontaneous tendon rupture, even though they are rare. Gastrointestinal effects and sensitivity to sunlight may occur in those who use tetracycline. That drug can be deposited in growing bones and teeth, therefore should not be given to children less than 12 years or pregnant women. Sulfonamide can cause blood dyscrasia, acute kidney injury with hyperkalemia, rash, Stevens-Johnson syndrome, vomiting, and diarrhea. Therefore, these side effects limits the use of sulfonamides even though they have good tissue distribution and are good bioequivalent. In this presentation, we talked about different classes of antibiotics and their mechanisms of actions. We also discussed the difference between bactericidal and bacteriostatic, broad spectrum and narrow spectrum antibiotics. On top of that, drug distribution for each drug was also discussed. Lastly, we highlighted the common side effect of each class of antibiotics. After learning this information of each antibiotics, I hope it will help you in the appropriate antibiotic prescription. Of course, those antibiotics are not limited. There are plenty of antibiotics in the market and also new ones in the pipeline. Thank you.